Hello, so I'm going to make video on MRCP Pulmonology. So let's start from pneumothorax management. The British Thoracic Society published updated guidelines for the management of spontaneous pneumothorax in 2023. The updated guidelines put less emphasis on the size of pneumothorax and more emphasis on whether the patient is symptomatic and the presence of high-risk characteristics. Okay, so and this is general algorithm. The first step is assessing whether the patient is symptomatic. The BTS define minimal symptoms as no significant pain or breathlessness and no physiological compromise. No or minimal symptoms, then give conservative care regardless of pneumothorax size. If patient is symptomatic, then assess for high risk characteristics. Okay, so these are the first step in assessing whether the patient is symptomatic or not. Okay, if a pneumothorax is symptomatic, the next step is assessment for high risk characteristics, like if patient is hemodynamically compromised, which is suggesting that the patient is having tension pneumothorax, and check for significant hypoxia if patient is not maintaining saturation, bilateral pneumothorax if patient is having underlying lung disease, and if he is more than 50 years of age with significant smoking history, and hemothorax. Okay, so these are the high risk characteristics, and if no high risk characteristics are present and it is safe to intervene, then there is a choice of intervention like a conservative care, ambulatory device, and needle aspiration. But if high risk characteristics are present and it is safe to intervene, and then plus chest drain. I hope everything is clear till now. So now let's how is safety or intervention determined? Before a needle aspiration, chest drain insertion, the safety of intervention should be assessed. It depends on the clinical context, but is usually 2 cm laterally or apically on chest X-ray or any size on CT scan, which can be safely assessed with radiological support. And management options: conservative care, a patient with a primary spontaneous pneumothorax that is managed conservatively should be reviewed every 2 to 4 days as an outpatient. Okay. If patient is having primary spontaneous pneumothorax, but if patient is with a secondary spontaneous pneumothorax, that is managed conservatively as well, but should be monitored as an inpatient. Okay, primary as outpatient and secondary as an inpatient. And if it's stable, then follow up in the outpatient department in 2 to 4 weeks. Okay, now let's talk about the ambulatory care. An example for an ambulatory device is the Mrcp pleural vent. It includes an 8 French gauge catheter mounted on an 18 gauge needle and a pigtail catheter to minimize the risk of occlusion. Ambulatory devices typically have a one-way valve and vent to prevent air and fluid return to the pleural space while allowing for controlled escape of air and draining of fluid. Many devices also have an indication diaphragm that signals when the catheter tip enters the pleural space and continues to fluctuate with respiration, aiding in the assessment of pneumothorax resolution. Okay. So, and needle aspiration, chest drain should be inserted if needle aspiration of a pneumothorax is unsuccessful, and if resolved, discharge and follow up in the outpatient department in 2 to 4 weeks. And this is the ambulatory device. Okay, so chest drain insertion daily review as an inpatient, and remove drain when resolved, and discharge and follow up in the outpatient department in 2 to 4 weeks. Okay, so a patient with chest drain should be monitored as an inpatient, and when it is resolved, then remove drain. Okay, now let's talk about the persistent or recurrent pneumothorax. If a patient has a persistent air leak or insufficient lung re-expansion despite chest insertion, or the patient has recurrent pneumothorax, then video-assisted thoracoscopic surgery VATS should be considered to allow for mechanical or chemical fluidasis plus minus biliectomy. Okay, and whatever we rate is mentioned in this algorithm, pneumothorax pathway. Okay. So discharge advice: if patient is smoking, then patient should be advised to avoid smoking to reduce the risk of further episodes. The lifetime risk of developing a pneumothorax in healthy smoking men is around 10% compared with around 0.1% in non-smoking men. And what is the fitness to fly? It's absolute contraindication. The CIA suggests patients may travel 2 weeks after successful drainage if there is no residual air. The British Thoracic Society used to recommend not traveling by air for a period of 6 weeks, but this has now been changed to 1 week post-check X-ray. Post-check X-ray means advice X-ray, and if there is any knowing pneumothorax, then he can fly. Scuba diving and the BTS guidelines state driving should be permanently avoided unless the patient has undergone bilateral surgical pleurectomy and has normal lung function and chest and CT scan post-operatively. Okay, so these are the chest x-rays. You can see here lung marking, and on the Pisces there is pneumothorax and lung is collapsed, but it is not tension image, is simple, and patients having emphysema as well on the right side. Again pneumothorax, lung is collapsed, and here it is pneumothorax. Okay, it's simple pneumothorax because mediastinum is not shifted. Okay, so stable COPD is stable management, and NICE updated its guidelines on the management of chronic obstructive pulmonary disease in 2018. General management if smoking cessation, and give smoking cessation advice, including offering nicotine replacement therapy, varenicline or bupropion, offer annual influenza vaccination, one-off pneumococcal vaccination, and pulmonary rehabilitation to all people who view themselves as functionally disabled by COPD, yearly medical research council, grade 3 and above. And it's about general management and bronchodilator therapy. A short-acting beta-2 agonist SABA or short-acting muscarinic antagonist SAMA is first-line treatment. For patients who remain breathless or have exacerbations despite using short-acting bronchodilators, the next step is determined by whether the patient has asthmatic features or features suggesting steroid responsiveness. Okay, and there are a number of criteria NICE suggests to determine whether a patient has asthmatic steroid responsive features. As any previous secure diagnosis of asthma or of atopy, higher blood eosinophil count. Note that NICE recommend a full blood count for all patients as part of the workup, and substantial variation in FEV1 over time, at least 400 ml, and substantial diurnal variation in peak expiratory flow, at least 20%. Interestingly, NICE do not recommend firm reversibility testing as one of the criteria. In the guidelines stated that routine spirometric reversibility testing is not necessary as part of the diagnostic process to plan initial therapy with bronchodilators or corticosteroids. It may be unhelpful or misleading. They then go on to discuss why they have reached this conclusion. Please see the guidelines for more